Nora. I think welcome everybody to the OHP Bridge Advisory Committee for January. I will hand it over to you, Nora.
Okay. Sorry, just realized that the document I thought I had open to tell me all the beautiful things to say is not open. Give me one second.
It's the new year, everyone. We're getting back to the swing of it.
Okay, I'm back. At least theoretically speaking. Or not. I want that open. Sorry. Okay, now I'm really back. Okay, so closed captioning should be available to all attendees during today's meeting. If you need access to these, there should be a button at the bottom of the screen that says show captions. You can click on that link and captions should begin to show up. Questions and comments will be taken from OBAC members only, with the exception of the public testimony portion at the beginning of today's meeting. If you're an OBAC member and would like to speak, please raise your hand before doing so. I think that's a message for me, probably. The Zoom chat feature in today's meeting only allows meeting attendees to message the host and the co-host, not to other meeting participants. Any questions, thoughts, and comments can be sent via Zoom chat to the meeting host and co-host. If you have supporting resource links to share with meeting participants regarding an agenda item that is being discussed, share the link with the meeting host or co-host, and they can share with meeting attendees. So, excellent. I don't know why this is not wanting to. Weird. Sorry. It's just not.
Do you want me to walk through the agenda portion, Nora, while you?
I mean, I can also read the agenda. So after that scintillating and not at all weird welcome and an overview, we're going to do roll call, we're talking about this agenda now, and we'll have meeting minutes. And then it'll be, as mentioned, the time for the public comment. Rather than kind of go through these, Katie, why don't you do your exciting roll call and I will try to figure out what's wrong with my computer.
Great. So as always, I'm going to call roll, and if you can please come off mute because I can't necessarily see you all while I also have my roll sheet open, and say that you are here, and we'll get going. So Debbie.
Here.
Yay. Katerina.
I'm here.
Mike.
Here.
Perfect. Eduardo. Eduardo, are you available? Okay. Jonathan.
Here.
Okay. Let's see. Mariah.
Here.
Okay. Angelica. Oh, I think Angelica might not be able to make it actually. Renisha.
Here.
Okay. Nora, you are here. And do we have, I know our ODHS reps are not able to attend today. Nikki, are you online for OHA?
She said she'll be 15 minutes late today.
Thank you for the reminder. Okay, perfect.
Katie and
Jewel Hallstrom.
Oh,
Debbie Burns is here. Eduardo's in another meeting, but I am here.
great. Thank you. Thank you, Jewel. Okay, back to you, Nora.
Okay, now I have 15 copies of the document open. So the one thing I didn't say before is that we are asking that all OBAC members remain on camera, if at all possible, throughout the meeting in order to preserve bandwidth. We also ask that non-members remain off camera unless you are providing public testimony. And all the materials for today's meetings are available on the OHP Bridge Advisory website, which is generally put in chat so that I don't have to spell it out. Okay, so great. So we're going to hear public comments next. I really can't speak today. To make it easier for members of the public to speak to the committee at a consistent time each meeting, we're doing it at the beginning. We do our best to ensure that public comment starts within the first 20 minutes of every meeting. With that in mind, today's meeting will include review and voting of the October minutes, public comment, general OBAC updates, a work session with, on the OHP Bridge communications that Katie will lead, supported by Maria Vargas and Sean McNulty, and a BHP Trust Fund financial update from Roger Rosales, updates on community engagement, and then we will close. So first order of business is to vote on draft OBAC meeting minutes. Is there a motion to approve the draft minutes? And that's a chance for all of you lovely people, any one of you, to say, yes, I move that.
Yes, I move to move forward with the meeting minutes.
Thank you, Debbie. Second?
I'll second it. It's John.
Great. Katie can take the vote.
Okay, Debbie,
Yes.
Katerina,
Yes.
Mike,
Yes.
Eduardo is as Eduardo Jarvis. Okay. Jonathan,
Yes.
Mariah,
Yes.
Angelica is not here today. Renisha,
Yes.
Nora,
Yes.
Kelly.
Yes.
Amazing. Okay. We pass then. Well done, everyone. Another successful round of passing minutes.
Thank you. Okay, so now we're going to shift to public comment portion of our meeting. The OHP Bridge Advisory Committee welcomes and deeply appreciates public testimony. To be respectful of everyone's time and ensure we're focused on listening, we will not respond to what you share, nor will we attempt to fix or resolve the question or concern that you bring today. We'll also not interject to correct any inaccurate comments that are shared as fact. We will take your comments seriously, understand it as an important consideration for our work, and listen with careful attention and respect. We want to acknowledge that time held in our meetings to hear public testimony is meant to provide a voice and perspective from each individual and is not a representation of the OHP Bridge Advisory Committee, its members, or the Oregon Health Authority. Each presenter has 2 minutes to share, and in the event it doesn't feel like enough time, we encourage you to provide written testimony, which we commit to reading. To help us on time, we'll start a 2-minute timer for each commenter. We kindly ask that commenters conclude their presentation when the timer is complete. Please know that written and verbal public comments will be reviewed and discussed following each meeting by the committee chairs and staff to determine the appropriate next steps. And anyone who's presenting can come on video when they present. Katie, do we have anyone?
We don't have anyone signed up, so I think we get another minute and then we can move on to the next part.
I will take that as my signal that we're going to move on to general updates. So Katie Waldo is our lead project manager for OHP Bridge, which seems very formal given, hopefully we all know you by now. And OBAC staff lead will be taking us through what's been going on in the months since we last met. So it's all you, Katie.
Thank you, Nora. Yeah, so welcome back, everyone. We just have a couple quick overview reminders, updates. This is the section of the OBAC where we just give you some updates on things that don't require a ton of slides, but we want you to be aware of. So we're going to start off today chatting through our 2026 meeting dates, as well as some changes to the meeting schedule. And then we'll have a quick update on enrollment. We're approaching some exciting milestones for the program there, so quite excited about that. And we will then be revisiting the start date adjustments issue that we talked about, I believe, in July, and we might have revisited for a short bit in October. So we'll just be letting you know kind of where things are at with that and what it looks like for this coming year. And we'll offer a really quick summary too for folks that haven't been tracking that issue. So to start off, Happy New Year, everyone. We're officially in 2026. We're on our quarterly cadence. So today is our first 2026 meeting. We'll be meeting again on April 16th, July 16th, and October 15th. We also are going forward planning to do 2-hour meetings. We know this is a change from our discussion back in October. In kind of the ever-changing healthcare landscape, we recognize people are oftentimes facing a lot of meetings, and with OHP Bridge in more of a place of sort of holding steady. We recognize that there's not quite as many decisions that the OBAC will be making or weighing in on for probably the next year, at least as we currently see it. And so we wanted to give you all an hour back in your schedule. But I do want to take a pause here and ask members if they have any concerns with this change, because we know this was different than what we talked about back in late 2025. Okay, I'm seeing some thumbs up, not hearing any major concerns. If, for instance, things do change and we have more decisions coming down the pike than we expected, we will chat with all of you several months in advance of making the meetings longer. So I think it's always a little bit easier to give people back time rather than go and extend the time on you. So we won't do that without checking in. Okay, on to the next. So we've got some enrollment updates for you all. This is our most recent data. So just a reminder that enrollment does change a little bit all the time, but currently our enrollment in OHP Bridge BHP, again, that's the program that serves a majority of our members. It's CCO only, is a little over 38,000 people. Enrollment in OHP Bridge Basic Medicaid, which is the subprogram that serves our American Indian Alaskan Native folks and ensures that they continue to have the choice between CCO and fee-for-service coverage like they do on Medicaid, is a little over 1,600 people, which brings us out just under 40K. So we're quite excited to be serving this many people in Oregon and ensuring that folks have a more of a continuous coverage experience as their income changes a little bit. Just as a quick reminder, when it comes to enrollment and how that might change as we head into the year, open enrollment does end today. And so individuals moving from the marketplace to OHP Bridge during that open enrollment period will continue to kind of come into the program throughout February and March, depending on when their application is processed. So we do see a slight increase in the number of people that come onto the program during open enrollment, just because this is when a lot of people are updating their applications and getting applications revisited. So we'll update you again on enrollment in April and are excited to see the program continue to cover more folks. Speaking of open enrollment, we wanted to give you an update, as I mentioned, on that start date adjustment issue. So this is also, I think we've called this the coverage gap issue that popped up during open enrollment last year. This was due to some unique interactions between the OHP Bridge and marketplace policies during this time. So one of the main things here is that open enrollment historically was one of the few times when the exchange would would automatically end coverage at a certain date. And that is not the case most of the year. So due to that, as well as OHP Bridge, the start date logic, there was some people that could have faced a coverage gap during this period of up to 2 or 3 months. So OHA kind of looked at that and tried to figure out if there was a way that we could offer a start date adjustment to help folks who had claims during this period of time, and were able to do so. And so in total, 9 people have reached out requesting this adjustment. So we're hoping this means that there weren't too many people that were negatively impacted by this. So that's just wanted to close that piece out. Regarding what this will mean for next year, or actually this year, due to some changes with federal guidance regarding allowing people to stay in their marketplace coverage until the start of their OHP or OHP Bridge coverage, this is no longer a thing that we will need to worry about, especially except for in very, very specific circumstances. So the coverage gap fix that we implemented last year will not be necessary for this year, which is great news. So in case folks are wondering about that, that's where we are at. Any questions about any of these updates? I will hand it back to Nora. And then I think Nora's going to hand it back to me.
Great. So thank you, Katie. We're going to move into a work session on the OHP Bridge communications. This is an essential function of the Bridge program and one of the key areas where OBAC input is especially important. With that in mind, we want to highlight that this is meant to be more of an active conversation between the Bridge staff and the OBAC members rather than just a presentation. Katie's going to be talking us through the session while we go through the various types of OHP Bridge communications and how they can be improved. So she's going to be joined by Sean McAnulty, Member Communications Coordinator with OHP, and Maria Vargas, who is the Communications Officer with the Office of Community Health and Engagement. Sean and Maria both play key roles in the OHP Bridge communications work and will be listening in today with the intention of adding context and responding to questions following up as needed. As always, OBAC members are asked to use the raise hand function so that we can see who's wanting to speak. And just so you know, the co-chairs and the staff had a conversation about our fervent desire for people to feel really comfortable weighing in. So hopefully you all will share all your good ideas as we go through this. So Katie, Sean, and Maria, welcome.
Much. Okay. So one of the things that I want to call out before we dive into this session, which I'm personally very excited about, and a huge thank you to Sean and Maria for being here today to help out and ask follow-up questions. Their work is very critical to making sure that folks know about this program and know where to go to look for more information and feel informed, both as members and as folks that might be helping members through the application and coverage process. As if you all remember back to when we talked about the reason for starting the OBAC, one of the key reasons we have this is to help us guide member and partner communications and outreach. So I'm really excited to bring you all in today. What we're doing today is kind of reviewing our main materials and resources, such as our website, FAQs, flyers, things like that, and kind of learning how best to potentially update and improve them. Obviously, as with any agency, we are operating within resource and staffing restrictions. So our hope in this discussion is to identify places that should be our priority as we begin this work. OHP Bridge is about 1.5 years or so old now. And so we kind of started this process a couple weeks ago of looking at how are we going to update these materials to reflect the fact that this is no longer a brand new program, that it's actively operating, and some of the ongoing changes just in the larger landscape. So our goal today is to learn from all of you kind of how you've interacted with our comms materials and outreach and things like that, how you're kind of interacting and learning from it, what's working, what's not working, how we can improve clarity, things like that. Does anyone have any questions about that before we dive in? Okay. So just a broad kind of setup to how we approach comms within the OHP Bridge space. So we've taken kind of a really broad scope approach with our communications here, which means we didn't have a lot of comms that were hyper specific to OHP Bridge. We kind of took more within the scope of what's called our Get It, Use It, Keep It campaign. And this tried to emphasize the fact that coverage was expanding within Oregon. And this was done for a couple of reasons. It was in part to avoid confusion around eligibility in the application process and encourage more people to apply. So we didn't want folks to look at the messaging and think, oh, I probably don't qualify for that, so I'm not going to apply. We really wanted folks to feel like they could go in and maybe even if they've been denied before, reapply and find out that they were eligible for something so that we could continue to push for that expansion in healthcare access for folks. We also wanted to develop materials that were as evergreen and adaptable as possible. Again, we work within sometimes a resource restricted environment. So wanting to make sure that we're using state resources as effectively as possible. So those Get It, Use It, Keep It campaigns really help us do that while also helping folks to recognize that coverage is continuing to expand in Oregon. It is now available to more people, even with higher incomes, which was really our goal back when we launched in 2024. So with that in mind, we're going to start out with just a really broad question. I want folks to kind of maybe think back to July 2024 or whenever you learned about the OHP Bridge program, and think about how did you learn about it? Was it through an assister, a provider? As a provider or assister, did you learn about it through a webinar? Was there a campaign that helped you hear about it and decide to look for more? Where did you see information about it? And once you'd heard about it, where did you go to get more information? I will start calling on people this time.
Well, I'll jump in, although this is Mike. I will say that I don't know if I answered some of these questions. I don't recall when I learned about OHP Bridge, but I do remember distinctly once I found out having to dive deeply into it because as an FQHC, there are certain payment mechanisms and structures we have that make the OHP Bridge population separate from traditional or OHP Plus. And we went down this giant rabbit hole related to MMIS and other things. And I want to say that was probably 2 years ago, something like that, around the time we started to realize the impact this could have operationally for us. I don't recall where I saw any information related to this, but I do know I was engaged with the Oregon Primary Care Association trying to find out information. I had also received some communications, I believe, from our local CCO who administers the OHP Bridge. I've had one or two distinct conversations with the team over at our local CCO to kind of understand how it works related to metrics and a few other things. So I know doesn't really answer the first question. I don't actually recall when I found out about it, but a lot of my information I've tried to find out about has really been leaning on partners I already know, like the local CCO, our local primary care association in Oregon, and those kind of resources.
I learned about it in a newsletter from OHA.
I know that Katerina has their hand up, but I just have a clarifying question, Katie. Is this specifically about us or can I also talk about the community we serve?
Yes, absolutely can speak to the community that you serve and also the others that fall within the community that you're representing.
Perfect.
Well.
Perfect. Thank you. So I can go after Katerina.
Close the business account.
Um,
That's very HELOC,
As
right?
far as when I learned about the OHP Bridge program, it was actually when I was just looking for expanding, getting involved in the community and I saw it on a job posting. Unfortunately, I work at a level one trauma center in Portland, and I had never heard that this was available. I had to actually go seek it out on the OHA website to get more information. So I don't know if that is helpful, but I would, with the patient population we serve, I'm surprised I hadn't heard about it.
Yeah. And so when you say it was on a job posting, was it mentioned as like you're familiar, we want somebody familiar with this program? Or
No, I just had it was for this the advisory committee. I had to actually go look to see, and I was like, with the patient population I work with, like this is huge. This is such a great resource.
Mhm.
This is the kind of stuff that I want to help advocate for. Let me learn more.
got it. Okay.
So I've mentioned it to a lot of our case managers and stuff because they actually go and help people enroll in a Oregon Health Plan. And so helping them kind of understand too, because we hadn't heard a whole lot about it.
So your case managers as well had not, when you told them, had most of them not heard about it?
Now, I want to say most of them, just some of them.
Okay. That's helpful. Thank you so much. Okay, I'm not sure who raised their hand next. Oh, Debbie. I think it was you, Debbie.
Yeah, so with specifically for OHP Bridge, it wasn't until I started really, well, I used to do OHP navigation, and that's how I found out about OHP Bridge and just through work. But oftentimes, well, most of the time, my community, which I serve, farm workers, low income, immigrants, migrants, they don't know what it is, and so it's really hard. Um, a lot of them don't qualify for OHP Bridge because they qualify for OHP. But when folks don't qualify for um, regular OHP, they don't know that there's also OHP Bridge. And so there's also like a learning curve with that. And then also there's not a lot of material or information out that's accessible to my community. And so having to do that education piece around it has been good, but it's also has had its challenges, specifically because we haven't gotten the training to have those conversations and to explain exactly like how it works, what it is, how you can get on OHP Bridge or anything like that.
Okay, that's helpful to know. And we do have a section on training later, so I'm excited to revisit that with you.
Perfect. Thank you.
All right, Mariah.
Hi. So, when I first learned about the OHP Bridge program, I was actually in a service integration team meeting. And so there was a presentation about it from someone from OHA. And we were all so interested in it. We had never heard about it. So then I started Googling it. I started connecting my clients to it. I applied for it and was accepted. And so it's just been awesome. And so I just am always giving out any resources that I can online about the OHP Bridge program because a lot of people don't think there's anything out there for them that they'll be approved for.
Okay, that's exciting too. We've got a bit of a section on like the website and flyers and resources on there. So excited to hear more about that and what ways you might expand, what was useful, things like that. That's great. Thank you. Mike.
So I just wanted to add to my previous comments. Like today, I do lean not heavily, but at least somewhat on my organization's billing and SDOH team. So the billing team understands a lot of the back end, who's eligible, what services are eligible. And we have an SDOH team that has several OSP assisters on it. And if I ever have questions or I'm kind of wondering what's going on with the program, maybe I don't feel super confident about or knowledgeable and I can't find any resource anywhere else, they are kind of my go-to and they help orient me to some degree because they're also interacting with our patient population. And I think they give me a better perspective on kind of what information is relevant to OHP Bridge, what our clients are seeing, because we're a safety net clinic for background. So we see individuals whether they're insured or not. And I find their perspective very helpful for me understanding not just OHP Bridge, the nuts and bolts, but maybe the impact on the community.
Okay, and I'm sorry, I think I missed it because I was note taking something. Do you know where they get their information on OHP Bridge?
Uh, they've told me, but I don't recall offhand right now.
Okay, no worries. Thank you, Mike. Jonathan.
Similar to what Mike had said initially, so I'm a provider. I work with a lot of Medicaid patients, and I don't remember where I first heard it, but I just remember hearing a lot about it from the Oregon Primary Care Association and also from one of the CCOs we work with, Care Oregon, we Nora works with, but we have a monthly meeting with them. So just in an update with them at that meeting.
And OPCA, were you hearing during meetings with them? Did they send out a newsletter or like a mailing for Oregon Primary Care?
It might have been in, I mean, it probably was in the newsletter. But I know that we talked about it in meetings with them too. So I don't recall exactly. It might have been like in like a legislative update monthly call that they do.
Great, thank you.
We partnered with them on our office hours and whatnot as well. So glad to hear that was effective.
Okay, Kelly, I know that you mentioned that you heard it through a newsletter. Do you happen to remember what newsletter?
It's just like an OHA like update. And it kind of every month, I think it's every month that I get it. Goes through a bunch of different topics, and it was one of the topics.
And then when you got that newsletter, did you then go like try to find the website kind of? Okay, cool.
Yeah, I clicked on it. Yeah.
That sounds slightly like Oregon Health News to me.
Yeah, I think that's, yeah.
Okay, cool. Well, I'm glad those are getting out to folks, reaching them, and that it included the website and made it easy to find. So, okay, this is a great start. We're going to dive into some of the more detailed areas. So speaking of the website, can you, if you are an OBAC member, can you use the raise hand function if you've actually visited the website? And I'll give folks a minute because I know it can take a second to find the raise hand function. But if you can hit yes to the raise hand function if you've been to the website.
If you need to visit it to confirm, ohp.oregon.gov/bridge is the easy way to get to it.
Handful. Great. Okay. All right. So thank you so much, everyone. For those of you who have used the website, we've kind of just got some general questions here about, did it feel user-friendly? What parts were helpful? What parts were not? Are there resources on that website that you've used? So for instance, I think Mariah, it was you that mentioned that you kind of hand out materials or information on it. Was that using flyers that were on the website, or was it kind of something you created on your own?
Flyers.
Okay, great. And were those like posted at your work, or did you sort of hand them out for people to take home? Did people seem interested?
Both.
Both. Okay. Great. Cool. What anyone else? Does it feel, what do we think of the website? Do people know how to find the flyers on the website? I know Mariah's obviously found them and used them. Have other folks looked at those?
Just a quick question. Is there more than one flyer? I know that's a ridiculous question, but I know there's like an outreach toolkit and you can click on the link and I only see one. But maybe there's other things on the website that I've not navigated this website super close. I've really mostly been to the landing page, but I've not done a deep search. I'm just kind of curious kind of how we would get those.
In addition to the toolkit part, there is a get, use, keep flyer, which is very generally enroll in coverage, apply for coverage focused. So it's more that broad spectrum aimed at the uninsured population. Only 7% or so of them were going to be eligible for bridge from our understanding when creating that sort of stuff. So for that one, we went very broad scope. It does mention bridge launching. And then the OHP Bridge Toolkit is much more specific, which is in need of annual updates right now that we're working on. So,
thank you.
And has anybody...
Similarly, if there are materials that would be helpful to have in that or something that don't exist or something, we'd love to consider those suggestions and see if we can make things like that.
This is Eduardo. I have not, but This is just particularly because of the population that we work with. They will not go to the website. So what we have done is we digest that information and then we guide them understanding their particular condition and see who may qualify for each program. So then if we identify someone, we guide them using the information from the website and then we refer to someone who can help them to apply.
So when you're using the website for that purpose, Eduardo, I know the folks that you're helping out might not be looking at it, but what are you normally going to the website to understand? And do you generally find that you can find the information you need on the website when you go there?
Yes.
Okay.
What we do is that we don't visit the website that often. So we have navigated the website a couple of times, pull the data out of there, and then we create our own materials so we can easily train our staff on what this is, right? Rather than saying, go to the website and try to understand it. And that's my particular situation in my work environment. But we have navigated probably 3, 4 times. It may sound sad, but it's just because that's how we use that information in that platform.
And are you checking back every once in a while to like see if there's updates to the information that needs to be shared, things like that?
No.
And we're
sorry, raw truth. It's just
so
yeah.
This is part of why we're doing this, is to see
Yeah.
how people are using it and where it makes sense to put the time and work that it
Yeah,
takes.
someone was talking about the bulletins. That's what I use. And I know it's not only for OHP Bridge, but I just use bulletins, right? So that's the easiest way for me because then I know which bulletin may apply for me, right? And then I go and digest that information heavily. Kind of the same that I did with the website and the information there. I just did one exercise of heavy data digestion.
Got it. Okay. And when you went on to do that kind of initial discovery phase of things, were you looking at the FAQ or were you mostly on just like the landing page when you just initially typed the address in?
No, I mean, I'll have to go again and start saying where, but what we look is like, again, trying to understand what this is, put it in simple for my staff, and not really not really there. We just use the main
Okay.
pool of information, like in the sections. So we kind of navigate up the big sections.
Okay, great. Thank you.
Mm-hmm.
Anyone else that's been to the website? Any thoughts, feedback, things that you wish were on there? Yeah, Mike.
So I'm hoping I'm on the right page. It looks like it's a little out of date. It just says things like uh, when it launches in July of 2024, like things like that. Like it'd be nice if it was refreshed to reflect, what it is today, or maybe just a little bit closer to today. I know if I were coming to this page, I'd be like, well, is this even still a thing? Should I be paying attention to this? I'm a little concerned that it might confuse some folks that go on the page.
I think we have, I'll have to double check exactly where that one. I remember we had written the update to that. I don't know how it didn't get applied. Let me double check that one.
Good for us to, this is why we're doing this. Because that is part of what we're going through on the FAQ, is making sure that everything is present tense, that it recognizes that the program is actively going and has been going for a while. So it's good to know that when you are searching it on your end, that it is still showing some of that language as being past tense.
The one other thing I would probably mention, I don't know if it's too super important, but I do think about individuals that don't have native English for their reading. And there's like partner research on the side. It says English, Spanish, Russian, but it's all written in English. I do wonder if it was actually written in Spanish and Russian and Vietnamese. Maybe somebody who's navigating the website who might want to come onto it would be more likely to click on it and actually see that flyer, because it goes to a flyer, which is what we want them to see. Just a thought.
As in putting the link in the language is what you're saying?
Yeah. Yeah.
There's also a fully Spanish site as well that you can flip over to. And then this isn't my favorite way to get other languages in there. Unfortunately, it's just a thing across all of our websites. There's a drop-down translation function at the corner. I can't remember if it's top or bottom corner. less than ideal. I like the idea of adding the language in language to the English page though, because that's the first one people are going to see most of the time.
Yeah, it's right under where it says, at least for me, en español, it says it right under that. But I'll be honest, I didn't see that right away. Like I saw the en español, I didn't see the translator, and then I saw all the links on the side written in English. And if I'm not a non-native speaker, if I don't speak any or read any English, like I'm not going to know what's going on here. At least if the flyers link is written in their language, they're more likely to actually click on that, see it, understand what the program has.
I like that one. Yeah.
I agree with that. I I think it's I think it look aesthetically appealing with the style of the OHA websites, but it's hard yeah, it's not catchy, I would say. I think it's properly placed, but it's not catchy or at this first eye.
I think also maybe having a section um like of definitions, for example, like especially in Spanish, the like no hay primas, and it's like, I'm assuming that means premiums, but what does premium mean? And so just like a section for like definition for folks, especially because, to be honest and to be fully transparent, the people that um I work with don't have access to internet, and or if they do, they're not really tech savvy, and they will not go on here and do research on them on their own to figure out what OHP bridge is. But if but for folks that do, I think it'll still be beneficial to add like a section of like definitions or anything or something like that.
Yeah, there is one about it's like in the lower half of the page right now. If there's things we should add to that, premiums isn't in there, for instance. So that one jumped out as a suggestion. I would love to get a list of things that you think would be helpful to cite there, for instance.
Okay, yeah, and I went through it, but I didn't even realize that that's what it was, like palabras importantes, like important words. So maybe putting it like on the side, like on a section while you're reading through. So it could be like on the side possibly. So it kind of like you can kind of then go to the side and read, oh, that's what that is.
Talk to our web designers and see if that's how we can lay it out there. I'm not an expert on the
Thank
formatting
you. And
stuff
I
there.
know it could be like aesthetically, it might not be pleasing, but also maybe having something on the side that could then directs them to the bottom of the page. That's where the definitions could be.
Yeah. If nothing else, I definitely think we should be able to do that. So that feels like a button we can make happen. And I like what you mentioned, Sean, with if you all think of a term that you don't see on the website that we have a definition for that you think would be helpful, feel free to drop it in the chat throughout today's meeting, and we will work to collect those and get them added to the page. So thank you, Debbie, for calling out that term probably needs to be added. Okay.
And then also just for feedback, also like if you ever need, or and this is just like overall for anything that has to do, because we did some translation for the PSAs for natural disasters. Um, I really do suggest to reach out to local CBOs that do this work to get the translation, because oftentimes, I mean, I don't know where y'all are doing your translation or who, if you have it in house or who does it, but sometimes that could also not translate appropriately. And so just for feedback and for future things.
We mostly go through contractors and then use our OCHA, our community partner engagement teams, Maria included, to do that review step of things, because that's definitely, we get mixed feedback on the quality of outputs like that. So
Okay. I do want to make sure we're continuing to move along here. Really appreciate all of this engagement. It's been great. Thank you so much, everyone. So we are going to move to the partner trainings and webinars. So I think Debbie, was it you that had mentioned that you the trainings or the need for trainings?
Yeah, it was me.
Okay, so we do have a number of trainings that we rolled out when we launched OHP Bridge. So for folks that interacted with those trainings in some way, or are getting updates through webinars or through OCHA, we'd love to hear kind of how that's been going, what we liked about the the trainings themselves, such as their length, platform material, and if there's anything you think should be changed or improved.
So again, for full transparency, so we are not assisters, but we do help community members, like try to guide them through OHP and try to give them as many resources as we can. And to be honest, when I have tried to get trainings or looked for them, it has been a challenge. And I can only imagine if it's a challenge for me, who that I know, how to work internet, I have access to a computer, but I also don't know if where I'm looking for them is their correct spot. So just for feedback, that could also be a challenge.
Yeah, I mean, our trainings can be as wonderful as we want, but if folks can't find them or don't know how to access them, that's a pretty significant barrier. So has anyone else here taken any of these trainings or attended one of our webinars that's related to OHP Bridge or general health news updates where we talk about OHP Bridge?
To just want to note that the OHP Bridge training, the overall one is kept within the same system as the OHP Assister trainings that we were just referencing there. So if we're not going to that source, that's the same place to find it.
Yeah, Eduardo.
I may be wrong, but I think the way that I got some of the webinars or trainings was through also an email or newsletter that perhaps redirect me through the website. So I do remember the email. I do, but I don't know how I got to that uh, section of the website. I just clicked the link, basically.
Got it. At one point, you put your email into a very important listserv, and it's coming through in a positive way, which is great. It's always nice to know
Yep.
people are opening those mailings that we send out, those email blasts that we send out, that they are going to people and that people are utilizing them to access the resources we share in them. So that's great news. Even if you don't remember which
Yep.
one it is, it doesn't matter. I'm just excited that they're making it to your inbox. They're proving useful. All right, Mariah.
Hi, yeah, I think that one thing that could be added that would be really helpful is like maybe if there was like a QR code or something just to like break it down, be able to connect you to apply, things like that.
Or to let you know about the trainings, like a QR.
Yes, or just even about Bridge in general.
Okay. So maybe on our flyers, for instance, if we include a QR code to take you to the website and things like that.
Oh, yeah.
Yeah. Excellent. Thank you. Katarina.
I think that's a fabulous idea. Like just thinking of while a lot of the um, people that I interact with who would qualify, they don't have a computer or things like that. But if there was a flyer with a QR code, I can totally see them utilizing a QR code more than going to search out a website.
Great.
It does have one. It points towards the, like, what am I eligible for estimator tool as opposed to the OHP Bridge website informationally. So whether or not to direct to one of those two tools, I think is something that we might want to potentially put one for the informational site as well or something on that line in the updated version we're working on right now.
Yeah, absolutely. I'm thinking about which one feels the most useful for folks, whether it makes more sense to send them to that tool that kind of tells them what they might be eligible for versus the website that tells them what a program is.
I was also thinking kind of both could be useful, as scan here to go to this,
And
scan here to learn more.
that thing they're telling you you might be eligible for is, yeah, definitely. Okay. I do love the accessibility of QR codes. So that's great. Okay, well, we'll keep moving along. So the next thing that we're going to look at is our eligibility notices and member handbooks. So these are the two main pieces of information that go out to members or potential members to help folks understand their benefits and what it is that they're eligible for. So I'm going to share these questions that are on the screen right now in the chat because we're going to kind of move along to what the actual language is so we can be responding to that. So I'm going to drop these and make sure everybody can see them first. hopefully this will come through in a fairly readable way. Okay, can everyone see those questions in the chat? Great. Okay. So we're going to start with our eligibility notices. So this is what folks receive when they learn they are approved for OHP Bridge. And Sean, I'm doing my best to explain this, but if I say anything wrong, please feel free to jump in and correct me. So for folks that have received a notice like this or who have helped individuals try to understand and process a notice like this, we would love to know kind of, did this feel, I mean, we understand it's government jargon to an extent, but does it feel accessible? Does it feel like you knew what information you were receiving and what it meant?
Understanding these are very bewildering notices and we're part of a whole large system and they have to be all automated. This is one of the few things that people will first see as their introduction to Bridge reliably, so would love to get feedback on this one in particular. There's also a couple updates queued, for instance, naming that those strings of numbers are OAR citations. We will have the word rules appearing in there soon. So,
oh, yeah, Mike.
So a few thoughts or comments. I think the first one is I'll go along with what everybody else said. I'd love to see a QR code on here instead of here's the link to visit the rules. I just think QR code's a lot easier. The other thing I'll say is that this may not be a part of OHP Bridge, but at least I know on OHP, when you get an eligibility notice sent to you, it's a giant packet with many, many pages. Like this, when I've seen it, it's been buried. Like I don't know where that should be. And, you know, I saw the note on the previous slide about, well, space in the handbook and eligibility is limited. Like, I don't know if that's part of the notice going out to them, but like, I just kind of wonder why and or maybe how that information is being conveyed within the other information that's coming with it. Because I'm not certain, but I imagine there's other things coming with this notice besides just this little blurb we're seeing right here. And I do wonder to some degree how overwhelming that can be for some of the individuals that are getting on OHP Bridge.
this is part of the same system as it may also contain an approval for food stamps, for instance, as well. So this is all part of a huge system that has multiple benefits of it. So yes, they can get really long. The federal government also required us to make some changes during the unwinding to individually lay out one of these pages for each member rather than condensing it for the whole household, which made it even further longer than it used to be. We're really trying to mitigate that as best we can. One of the things we did that this page you're seeing here is the individual outcomes screen that'll appear for one for each family member. Before they get to that, though, we added a page one kind of color-coded grid for the whole family that says whether, like, it'll put a green check mark color-coded that this is an approval. It has a very brief summary that they've been approved for benefits with a start date, or orange if they need to take action, red if they were denied, or benefits are ending. So we tried to take some steps to color code the information up front, and then they'd go into each household member's specific outcomes, which is what we've got on screen here. So I can, we can probably in the post-meeting email get a example that has that first page as well, if that full context is helpful. But yes, we definitely agree with the general sentiment that these are bewildering for folks with the level of information that's in them, and are trying to minimize that however we can.
Yeah, and I really want to echo that, especially when in Spanish. And to be honest with you, I'm gonna fully transparent that even when I get those, like I'm like, what the heck is all this? And so it's a lot of jargon, and I understand that sometimes it's needed because of X, Y, and Z, but it could also be intimidating when somebody gets like a stack of papers coming from the state and you don't know like what it is. And so I've read plenty of them for community members that come in through our doors that need either translation or it are in Spanish, but they still don't understand what it means. And then also because some people don't know how to read. But it is a lot of it is intimidating when you get like a really big stack of papers just to tell you that you are approved.
One other thing I'll add, sorry, let me put my hand up. This is more semantics more than anything, but it's because I'm from Maryland originally. When I see the OARs that are 410-200-0438, those are like phone numbers to me. and I don't see OAR in front of that. Like I know we're in Oregon, so it's not a big deal for me, but I actually still have a Maryland number. Like it, I do worry to some degree somebody might look at that, think it's a phone number they have to call because OAR is not in front of it. Just a little bit of a semantic thing, but I'd be a little concerned maybe about that to some degree. That's probably not a big deal, but for
Yeah,
me,
that's one of the updates we have queued.
yeah, my first initial thought was like, wow, I'm getting a Maryland phone number on this. This is kind of crazy to me. But reading farther down, I realized there's an OAR. Just a thought of maybe put OAR in front of that.
Yeah, that's the update we have queued it's coming. I say it's February. I can't remember for certain that it's in there or the following one, but we have a bunch of small cleanups to the titles of these fields. We're just removing benefit and adding start date and keep leaving just start date as well as adding Oregon rules. To that, we are unfortunately required to cite the rules in the notices. I don't think it's a great effective way of communicating to members why they weren't approved for a specific program or were, but that is one of the required elements, unfortunately. But trying to do that and actually tell people what we're saying there rather than
This is
just on context-free codes and strings of numbers aren't helpful. Yeah.
Yeah, that is helpful call out though, Mike, because anytime I work in rules, I didn't think about the fact that they are set up 334, which is a phone number setup. So that's just helpful for me on a personal note when I do comms out about rules to think about that because it does look exactly like a phone number.
One other question I will ask, it's more maybe for the other members of the group that maybe assist more than I do clearly. Is the list of services that are covered the ones we actually want to have listed? Like there's more than just what's listed there that they have eligibility for, like that they have a part of their benefits. Is that what we want to have listed there? Are there other things we want to call out? I'm thinking about maybe the patient population we're trying to serve. Is there something else that might be beneficial to highlight there, or something we want to maybe add? Just I look at that, I don't see anything about going to see a specialist, for example. Like just that kind of level. I don't know if we need something like that. And I'm just throwing it out to the group because that's where my the other kind of comment that immediately came to my mind when I saw this is like, oh, what's listed here? I'm like, wait a minute. So checkups, what if I need to go get vaccines? Like I think about certain things like that.
Yeah.
That is,
Oh, go ahead, Sean.
oh, sorry. I just want to provide context. That's also the notices for OHP, so I'd value that same feedback for OHP generally. There are many other benefits, for instance, rights to care as well, that we could get added into there. So taking notes for both those programs on this one.
You. I'm not sure if this is something that maybe we could do, but maybe also potentially because I know that there are some organizations that are assisters that can help, with navigation. So also maybe potentially adding, you know, a list of nonprofit organizations that can help people direct them to like, we are not assisters at Centro, but we do help community members navigate their benefits and we help them do appointments. So maybe something like that along the, I mean, I don't know with this, I mean, we could get people that are like racist and that they don't want, those specific services on there. But I think that for the overall population, I think it would be definitely beneficial. I mean, we don't turn anyone away, but anyone can receive these services because we don't know when they're, going through certain situations that they could potentially need that assistance.
That is on the letter as well. It's usually somewhere right before this. There will list the specific community partner or sister. If they have one attached to their case, that contact information will appear for them. That way they can contact them back. If they don't have one on file, it's going to list the link to the locator tool. That way they can find them one for themselves if they want to.
And so that could be potentially hard for community members who can't navigate online systems or anything like that. So maybe adding just like a page, if possible. I know I said like, a stack is intimidating, but it could potentially be just like a page where you maybe just add a list of organizations that not only are assisters, but also like Centro who and I don't mean this so you can add us, but I mean it so like other organizations that maybe aren't assisters but could also be beneficial for the community.
I want to jump to that. I agree, or even to a way to distribute it with other partners organizations. Perhaps we were referring clients to partners, and then we didn't know that those partners were no longer offering the service. So I know that may be another labor intense task to keep it updated, but it will be valuable to, yes, as Debbie was saying, consolidate it, not just to the patients, but to other organizations, and somehow have some sort of update quarterly or something in that nature.
Yeah, and really, I'm sorry, Mike, I know you have your hand up, but just on the same topic really quick, with that, we've also had experience where community members have came in and they're like, well, I called this specific organization, but they never helped me, or X, Y, and Z. So at least that gives them a list of other folks that they can call. So then if someone doesn't, maybe they don't have availability or for whatever reason, they can't help them, they can always reach out to somebody else on the list that could potentially help them with whatever service that they need.
Thank you both.
I'll talk with our community partner people about this. I do think part of this is the benefit of the assister structure, though, is we have these systems built to keep who is currently certified as an assister up to date and communicate those lists out. So getting beyond that to other organizations and keeping track of them as well gets a bit more challenging. So let's I'll mention Maria here is here listening as well. We'll talk a little bit about this and see what we can do there. I like where this is headed, but operationally might be challenging for some of these. So.
Yeah, it's a helpful idea to take back and think, like you said, Sean, think through and talk about what options might exist.
Yeah, and I'm sure that Eduardo and I would be more than happy to have conversations with whoever we need to make this happen or advocate for our communities for them to have that accessibility.
Absolutely.
Thank you both. Okay, Mike.
Sorry, I just keep on coming up with things. Apologize. What the other thing that kind of stood out to me was health related social needs. I'm wondering how many people would actually know what that is. Like, it's nice to see it in there. It's like, oh, go to this link about more program benefits. Like, I work in this space and I know what it is, but I don't know if people that are receiving these notices may or may not know what that is. I'm wondering if there's a way to clarify that to someone. I'm thinking back to, I think maybe it was Debbie who made the comment about the definitions on the OHP Bridge page. That's one I know if I were to give this to my wife, for example, who's not involved in OHP like this, she'd be like, I have no idea what in the world this is. Was that I didn't even know that was a benefit. It's not a benefit. It just I wonder to some degree, because the first sentence to me reads pretty clearly, in my opinion, but doesn't cover, and then it's a series of words. I have no idea what it is.
I knew about it just probably from the newsletter, and then I was wondering what it was, so I clicked on it and read about it.
Would it help if we provide the examples of housing or nutrition benefits? That's shorthand that gets used in other places.
I would say yes. I mean, I actually think probably Debbie or Eduardo or one of them would probably have a better understanding because they're probably working more directly with the patient population that we're trying to serve with OHP Bridge. But like that was my reminder initially when it's like, what are some examples of health related social needs? When I read that, it's like, well, anything could be related. And what's social need? I just worry that might confuse individuals more than help them, depending on their background related to our health insurance system.
Right. Yeah, Jillian.
Hi there. I like what Mike is saying, and a thought just for awareness is, if you say things like food or housing, being aware that some programs for food or housing will accept that you are on OHP Bridge as an eligibility criteria, right? Like, oh, you're getting this other public assistance, therefore you're automatically eligible. So just being cautious of the language, like we know we're talking about OHA and ODHS, but does the person receiving this understand that OHP Bridge, like if we say it doesn't cover those things, right? That it doesn't necessarily mean it might not cover those like grant or community type benefits that exist out there that rely on public assistance recipient proof for their sole eligibility criteria. So just to think, just noodling is all. I don't want to shoot down a good idea either. I think it's achievable, just a thought.
Yeah,
Also,
and I appreciate that. Yeah, and I appreciate that, Jillian. I know explicitly well how that works. I appreciate the call out, and to me, it's just I want to make sure we're giving the information to the individuals in a way that they can digest and understand it. And maybe how it's written is right now is that way, but I don't quite know. That's why I'm kind of hoping that this will stir some conversation around it. To me, this kind of leads to the QR code again. Like you want to learn about the benefits, go to some rule somewhere on some website somewhere else versus let's go to OHP Bridge, have you walk through the program, or go to an OHP Assister website where you can go and take a look to see it. Just I'm trying to think through what would be easiest for the members to actually understand what that is.
And kind of going off of that, oh, sorry, Sean, do you want to close out that?
Oh, I was just going to try to explain what we're going for with that sentence. As part of that is that OHP Bridge is entirely identical to OHP Plus, except for those two specific services. That's why they're cited in there. Trying to convey that difference, I think, is the main thing we're trying to do with this whole thing. If there's a better way to achieve that intent. Also, just wanted to mention the long-term services and supports. We also have some language that gets used about services that help people meet their daily personal care needs. We could potentially use those things in there, but kind of throwing out those other options in the general, what we're trying to do with that, if that is helpful for folks in feedback. Sorry, Katie.
No, no worries. I know that we are quite a bit over time. I did want to mention or just ask with one follow-up question to you, Kelly. You mentioned that when those things had been mentioned in a newsletter that you'd been able to follow the links to find the information on that. So was that was a separate newsletter you received kind of before you got the notice, or how did those kind of work? And did you see it in the notice and then you were like, oh, then it came through on this newsletter and I'm going to go check on this?
Yeah. I don't know. I have an interest in like how Oregon Health Plan works. And so even before I was on this committee, like when I got the newsletter, if there was something I didn't know what it was, or it was a new program or an announcement, then I would read about it.
Okay, great.
I don't know, does that answer your question?
No, it does. It's helpful
Okay.
to know kind of if folks are being prompted by getting their notice to go like Google these things, or if they're hearing about it through another avenue and then that's giving them the context that they need. So it's all helpful for us to figure out where are people actually getting information that they're looking for. So that's super helpful. Thank you, Kelly. I know we have a couple more slides left on this, but we are quite a bit over time. So I think what we'll do is pause here and we'll come back in April. We've already got an amazing amount of very helpful information from you all, so I really appreciate it. And so we'll come back in April and we'll kind of finish this work session out. We might add a little bit onto it from the things that we learned today. And I know Sean and Marie and I are probably going to be taking this back to start doing the edits that we're already doing now. So again, huge thank you to everybody for participating in this. I will hand it back to Nora to head to our break, and then we'll go on from there. But thank you all 1,000 times over. Really appreciate it.
Okay. Thanks. We will be now taking a 10-minute break, and we'll pause the recording and see you back here at 2:25. Back in and getting your cameras on. I will welcome Roger Rosales, Senior Actuary at OHA. He's going to be guiding us through an update on the BHP Trust Fund financials, including a discussion of capitation rates, risk sharing, and what all of this means for the trust fund. If members have questions throughout the presentation, please use the raise hand function so that we can see you. All right, Roger, we're ready for you.
Hey, thanks, Nora. Can you all hear me okay? Awesome. Welcome, everybody. I don't know if I've met all of you, but I'm the lead actuary at OHA for BHP, and so happy that it's been So successful and it's growing to almost 40,000 people. So yeah, we got a lot of math in here, but I'll try to keep it at a not so complex, but please ask questions if you have them. Yeah, we'll talk about the BHP trust fund and everything that goes around that. So it's pretty complicated. All right, we could go to the next slide. So today we're talking about how were BHP capitation rates developed for 2026 and how does this differ from 24 and 25? And I know we're kind of running out of time, so I'll try to end around 250 here. Recall that BHP capitation rates are like, hey, we got our CCOs out there, they're covering members for BHP. OHA pays the CCOs money through capitation rates to cover those members' services there. So that's what we're talking about there. What risk sharing mechanisms could occur and how do those affect the BHP trust fund? Yeah, we'll talk about risk sharing mechanisms between the state and CCOs. And then how does BHP trust fund spending compare to federal funding? I'm actually going to pass those two slides to Tim Sweeney to talk about that interaction there with CMS and all that. So we could go to the next slide. Prospective cap rotation rate development. Next slide, please. All right, so we got to set the table a bit. We'll talk about some key term definitions. We'll talk about the capitation rates for BHP from 24 to 26. And then I think everyone's pretty curious about the BHP experience versus Medicaid experience and how that kind of cost data informs the capitation rate development. All right, next slide. I hope this gets into what you all were asking. I got the request, so hopefully this presentation touches on that. All right, so definitions. You're going to see these words throughout the slide. So first one is unit. Unit refers to the quantity of a service or an item provided to a patient. So for example, if one of us goes and gets 15 minutes of physical therapy, that's 1 unit. Or we get 1 injection of a drug, that's 1 unit, or 1 office visit. Those are all considered units. When we talk about member month, if let's say we're all enrolled in BHP, we would contribute 1 member month for like the month we're enrolled. So if we're enrolled for a whole year, we would contribute 12 member months. So it represents 1 enrolled member for 1 month. When we talk about utilization, I just want you to think about like on average, like how many units of services per plan year is there. So let's say I get 10 things done, 10 medical units done. That's like the average for the year. And then this number kind of, you could see it as like a probability in an actuarial sense, but we multiply it by 1,000 to get like how many units of services per 1,000 members. So just think of it as like a rate of usage of services. And then we talk about unit costs. That's the cost associated with like a single unit of a service or a product. So yeah, got this injection done. How much did that injection cost? So 1 unit and then the unit cost for that. And then when we talk about encounters or encounter data, that's like records of services provided to members to CCOs, including the amounts paid to providers. So kind of think of that like claims data or something. We call that encounter data. Okay, next slide, unless there's any questions there. I know we're all itching to see the results, I guess. Where does this data come from? We got managed care encounter data from CCOs, the coordinated care organizations. We got member level eligibility and enrollment data from MMIS, or the OHA Medicaid Management Information System. What time frame we're looking at with this data? We're actually looking at when BHP first started in Oregon, so July 1st, 2024 to December 31st, 2024. So it's the first 6 months of BHP when it launched in 2024. We're actually not going to look at 2025 data yet because, yeah, we're just going to look at that initial period right now. What are we trying to get out of this data? Just see how the BHP members spend dollars and then recognize any patterns for the future. We could use this data to look at spending, set benchmarks, set assumptions for future costs, look at trends, and set the capitation rates. So yes, we look at this data all the time. Okay, next slide, please. All right, finally got to the data here. I know we mentioned earlier today that BHP is approaching 40,000 members, but when BHP first started July 2024, we started just over 20,000. It's kind of ramped up to like 30,000 and slowly going up there. I think a lot of people had assumptions what would happen with BHP. Where would people come from? Would it be a big influx coming in? Would it be slower? But we actually have like data now to show us the trend here. Again, people for BHP came from Medicaid. They came from the marketplace, and they came from other coverage or no coverage at all. So that was really hard to project back in 2024. It was really best guess assumptions on what was going to happen here, but we actually have real data now to help us. So looking at that July to December 24 kind of period, just some benchmark numbers here. You got average members of 24,000 about, utilization per 1,000, 23,000 units about are used per year by 1,000 members. The unit cost is 157, and then the PMPM cost is 302. So PMPM stands for per member per month. So like, yeah, total dollars there per member.
So Roger, we've got a hand up.
Yeah, go ahead, Nora.
Thanks. I understand the average members, and PMPM makes a lot of sense to me. What I don't understand is the value of knowing utilization per 1,000 members, because that, my sense is utilization is anything from a primary care visit to an inpatient stay to SUD, I mean, like everything.
Oh, for
right?
sure.
So like, what is it that we are, I mean, other than knowing a PMPM, average PMPM, which is understood, like, you know, people use about $300 on average, whatever. What is the value of knowing there were 23,000 services? Like, is it just to establish a PMPM? Like, because I'm looking at that and I'm like, knowing that the average unit cost is $157, I'm like, that doesn't mean anything to me.
Mm-hmm. I hear you. Yeah, Nora, I think we definitely look at it by category of service. So, I mean, this is kind of a benchmark looking at it over versus Medicaid, or looking at it year by year, just in total for BHP. But like, really, we want to dive down to the by service category, and we're going to get into that soon. Yeah. Thanks for your question. We can move on. Okay, so you saw that data. Now we'll talk about capitation rates. I mentioned it briefly, but these are fixed prospective payments that a state makes to a CCO on a per member per month basis to cover a defined set of healthcare services for enrolled beneficiaries. Yeah, hopefully that all kind of makes sense. So CCOs have members, and those members are going to have costs associated for being in the BHP, and the state's going to do their best guess on how much those costs are going to be. Yeah. Okay. Risk corridor. Sorry, Katie, do you hear a buzzing on my computer? Or is it okay? No. There you go. This fan is, I might need a new computer. This fan is going wild sometimes. Okay. Risk corridor, touched on it briefly here. It's a financial risk sharing mechanism used in CCO contracts where there's like significant uncertainty, and it just adjusts revenue paid to CCOs to be closer to actual expenditures. I'll just say there's like, when this program started, there was a lot of assumptions, wasn't sure what's going to really be happening here. The state has some risks, the CCOs have risks. So we have these risk sharing mechanisms like the risk corridor to kind of not make the financial hit so hard for both sides there. And we'll get into this more in a bit. And then what we're going to compare BHP to is the Medicaid ACA expansion eligibility group. And these are in Medicaid members 19 to 64 who have a household income up to 130% of the federal poverty level and not eligible for other eligibility groups. So yeah, that's where we're really going to kind of compare BHP because that's ages 19 to 64. And then we're going to compare it to the Medicaid groups here. All right, next slide, please. All right, let's talk about the BHP capitation rates over time. Showing you on the slide there for policy year 2024, we have ages 1934, 35 to 44, 45 to 54, 55 to 64, and a total amount there. And this intuitively makes sense. The cheaper cost for the younger people, $380 versus the older people, it's $825. And here I just want to let you know that when we set rates for 2024, we use data from 2022. There's always like this 2-year lag between the real data and then setting the capitation rates. So we looked at, the people that we thought would go in BHP. We looked at their Medicaid experience for 2022 and had to make best guess assumptions for people coming from the marketplace and insured populations. So as you can imagine, there's a lot of kind of best educated assumptions here, but we didn't really have the real picture there of what's going to happen. So we go to the next year, CY25, and I just want you to look at how the rates change from year to year here. In 25, we got a bump up from $514 of the capitation rate to $548. And here for 25, we looked at the Medicaid experience for 2023. Again, from Medicaid, and then best guesses for marketplace and uninsured. And our consultants helped us with that. But again, not using like the real BHP data. And then the next slide. So yeah, you see the increase from 24 to 25, and then you see this decrease from 548 total dollars to 491 for the capitation rate. And setting the 26 rates, we actually use the 24 BHP experience that I have been showing you. And I would say like our best guess assumptions were costs were higher than we thought. And then when we actually looked at experience and all that, we had to lower the capitation rates to reflect that real experience there. Okay, we could go to the next slide. Unless anyone has questions, feel free to raise your hand. And just know there's like a 2-year lag here. Okay, next slide, please.
Roger, I've got a question.
Yes.
Sorry, I had my hand up.
Sorry.
Maybe 2. No, that's okay. I'm kind of curious. I've got maybe 2 or 3 questions. First one is, a couple of slides ago, you said the PMPM cost was like 302, but the capitation rate's 491. Where does the other 189 or whatever that difference is? Where does that go in the system? Where's that in the system? And then I'll ask my second question after that.
Oh yeah. Yeah, that was kind of the 302 is kind of like what we call the base data, but you don't really have these admin costs and all these kind of programs that we have, quality pool, and there's probably some repricing of other stuff that's happening that's not flowing from the 302, but later on. So I think the biggest thing is like any taxes or admin stuff.
Okay. I guess part of the reason I'm asking the question is I'm wondering like, which is the important or more important piece of data? Is it the 491? Is it the 302? Is there something else related to that? That's more just me kind of thinking out loud to myself. Second
Oh,
question
sure.
I have is, I know there's a 2-year delay, it looks like with whatever kind of data we're going to use to come up with the rates. Is there any concern that in light of what's happened with the CCOs over the last few years with the inability for whatever the methodology we've had to make it so our CCOs can get by? Like, is there any concern that that methodology that we're using could result in something similar because we are using older data? I'm wondering if we've learned from the experience of the CCOs the last couple of years to move our analysis maybe to something that's maybe a little bit more, I might use the term realistic. It seemed like it was good for a long time, but there's something in the system where the last couple of years with the CCOs, they really have not been able to do what they needed to do, at least on the OHP plus side. I'm wondering if that is built into the methodology we have here.
Yeah, I hear you, and I hear what you're talking about. I mean, we use 2 years, and then we have trend assumptions to get from the 2 years to future state. And I know on the Medicaid side, there's a lot of stuff happening like, hey, can we look at emerging data and can that inform the trend or can that inform other stuff? So I think it's kind of a combination of like if OHA doesn't feel it's adequate or the consultants don't feel it's adequate, I think there's always the option to look at emerging data and make adjustments. But yeah, you just got to balance out like have all the claims come through. Then you got to deal with run out and how do you assume that stuff? We just want to make sure all the claims are kind of at a steady state when we use it. But I hear you. 2 years is some time there.
Yeah, and I appreciate that because my first initial gut response to this entire side was, ooh, 10% drop in PMPM going to the CCOs, and I know they have fixed costs. I'm just kind of thinking out loud right now with a lot of this stuff, but I just wanted to kind of see how that process worked. Thanks, Roger.
Yeah, thanks for your comment. Go ahead, Nora.
I was just going to say, I think one of the sort of to get at Mike at your question, one of the things that would be really interesting, particularly over time, not just the 2024 utilization, but moving forward, seeing what 25 looked like, is to what extent does this population look different on a behavioral health utilization and costs than the equivalent age folks in OHP plus, because for many CCOs, including but not limited to my own, we were spending significantly more on behavioral health services than we were getting in capitation. And I'm interested because, these are folks who could be, initially were coming from that population, but then new people coming in. And so I think one area I could see the capitation diverging, just being less costly, is if this was a population that had fewer behavioral health needs in terms of, going to seeking a lot of services. That is, I call that one out, especially because I think you're right, Roger, that like if OHA sees that there's the need to look at more recent data or Mercer or whoever, but also CCOs spent a year making the argument that what we were seeing was not normal, like that there was this big spike before OHA agreed. So the other part I would put in is like, CCOs are paying attention to this kind of stuff too. And so we're likely the like canary in the coal mine where we're like, something's happening over here.
For sure. Thank you, Nora. Yeah.
I just wanted to chime in real quick. I think some of this, also the context of some of this will become more clear as the slides go, and there's some of this Medicaid BHP comparison. I do think it's fair to note that the initial cap rates, I think, were likely a conservative rate development process, because the worst case scenario is we developed rates that did not pay enough for the cost of delivering services, right? And I think there was a very conscious effort to lean closer to the Medicaid rates and the Medicaid population, even though we had, I think, from a policy standpoint, a pretty strong reason to believe that this program, the members in this program, would be less expensive. We worked closely with other states that have BHPs, and they saw that their programs were less costly than the Medicaid expansion population, than that cohort. And even though there's a lot of similarities and there is movement between the programs, there also are certainly going to be differences in the healthcare needs of folks at different spots in the income scale and for a variety of other reasons. And so I do think it's not, from a policy standpoint, surprising that the cost of this program, the cost of members in this program, is a little lower than in Medicaid, and that we've seen this change. And I guess I would also then remind, from a cost standpoint, that the risk corridor exists. And so if the CCO experience shows that they're spending, that they need to spend significantly more money than the state is paying them for this population, they'll be protected in that risk corridor, and vice versa. That if their experience is lower, the state may receive payments back. But just wanted to remind, from a policy standpoint, that it may not be terribly surprising that there's a difference in the populations. And that said, maybe I'll stop talking so that we could see some of those charts.
Thank you, Tim. Thanks for the discussion. I think everyone probably got these slides beforehand, so I think we're going to jump around a little bit just for the interest of time. I want to make sure you get to the last two agenda items for the committee here. So whoever's controlling it, could you go slide down, please? And then maybe one more. Yeah, thank you. So here we'll look at the BHP kind of experience versus Medicaid. And just look at the utilization. You see that Medicaid adults are higher utilizers than BHP. Their unit cost is higher, 157 for BHP versus 183. And then the PMPM cost is higher as well. So that answers that question of the experience between the two groups. Can move on to the next slide, please. Yeah. Nora, this is probably what you're getting at. BHP PMPM costs by categories of service versus Medicaid adults. And yeah, you could just look at the different categories here. And I think across the board, you just see Medicaid being more kind of expensive than the BHP, and the mental health, non-inpatient, $46 PMPM for BHP, $57 for Medicaid there. So yeah, that's the breakdown of the by service there. Kind of seeing it across the board. Next slide, please. We have a lot of charts here just comparing BHP versus Medicaid adults and by the age cohort. And you could just see how BHP is kind of lower than Medicaid across these many categories. Next one is like physicians. This one's prescription drugs. Yeah. All right. And can you please go to slide 44? I think it's down there. There you go. So just kind of comparing year-over-year comparisons, BHP's rate change versus Medicaid ACA's adults. And you could see that Medicaid went up a bit there, 10% by that oldest category, and BHP came down just from the experience we're seeing. And next slide. Yeah, ready at 51. Do you all want to hear about risk corridor and retros, or too much detail? Keep going. How are we feeling, Katie?
I think if folks have the slides. Go ahead and read through them. If you have follow-up questions, feel free to send them our way, and we'll do our best to address them either in writing or follow up in some way.
Yeah. Okay. Yeah. So just very quickly, risk both sides for the state and CCOs. So we have a risk corridor in place for BHP. So CCOs are expecting they're going to get this amount of revenue from the state. And if expenses are way more than the revenue or way less, then there's a risk sharing agreement to pay money back to the state, or the state gives more money, stuff like that. And also the retroactive risk adjustment, that's just about like each of the CCOs have different populations, right? And some have healthier members and some have not so healthy members. And this adjustment is just going to like look at their kind of risk scores and all that and kind of adjust it between the CCOs. So it's not so unfair. But yeah, that's kind of the retro piece there. And Tim, did you want to speak a bit about the trust fund and CMS if we have some time?
Sure.
Okay. Go for it. I think it's slide 51.
So just at a high level to tie this back to sort of the financial health of the trust fund, and I think some of this is review, but from the trust fund is where we deposit federal BHP payments that we use to run the program. Spending happens in the form of the monthly capitation payments to the CCOs and fee-for-service payments for services that are not part of the CCO contract, certain mental health drugs, mental health residential, a handful of other services as well, and the managed care tax that CCOs have to pay is built into those rates. Again, revenue comes from the federal government and a formula that is based on the value of tax credits that would have been paid or would have been received by the individuals who are enrolled in the program. And then, as Roger just alluded to briefly, the risk corridor can sort of impact spending or revenue, if we owe additional payments to the CCOs or if the state is recouping money from the CCOs. And the next slide, then we can get it just trying to be quick, but at a very high level, the margins in the trust fund, whether we have surplus or not, is driven by the spending and whether the revenue that we get, covers that spending. And those change based on marketplace premiums every year, potentially from federal policy changes that affect the payments to states. In 2024, as a bit of a recap, spending and revenue are expected to be very close to the same. Like our projected margin for 2024 is extremely narrow. I think when we launched the program, we expected that perhaps the state would have to make some minimal contributions to ensure the in 2024 we had enough money to pay capitation rates, or there might be a very small surplus from higher federal payments. We're in the reconciliation process now, and so we'll know more in the coming months as to sort of the final reconciled 2024 figures. In 2025, both spending and revenue increased, but revenue growth was significantly more because of some components of the federal funding formula that were available to Oregon in 2025, but not 2024. And so there's expected to be a more substantial margin in terms of revenue for the program exceeding program spending in 2025. In 2026, we still expect that revenue will exceed spending on a global level, but the revenue decline, largely from the loss of the enhanced premium tax credits on the marketplace side, that leads to less per member revenue for the program, coupled with the spending decline because of the capitation rate decreases, that we just saw. results still in a smaller but still positive margin for 2026. All of these, especially going forward for 2026, depends a bit on the age distribution of members. It depends on a variety of things, and we'll learn moving forward if the sort of experience data that was presented for 2024 continues to hold true, or if a changing population kind of changes that dynamic in terms of the relationship of our costs and revenue. I think broadly speaking, we view the surpluses as especially useful to provide cushion for unexpected spending or federal policy changes that decrease future revenue. But also it's worth noting that the initial direction to the agency from the task force that developed the program, or that recommended the creation of the program, also directs the agency to do some analysis around the trust fund surplus and offers some prioritization should surpluses remain in the future, and we aren't as nervous about the risks associated with federal revenue declines. And with that, I think we're just about at time, so I will stop, and certainly if folks have questions, we can take them and get responses to y'all down the road.
Thank you both. Nora, back to you, I think.
Okay, thank you. So thanks to everyone for your time and your explanations and responding to all my questions. So we're going to be turning it over to Katie for some community engagement updates. Back to you, Katie.
Yeah, so I'm going to go ahead and I think we can go on to the next slide. We don't have any major sort of community engagement opportunities coming up, but we do want to flag these two web pages. We know folks continue to have questions about federal changes and what they mean for the agency and various programs. So I've dropped those links in the chat. We do want to note that we have kind of a broader federal response page that's tracking a wide variety of federal policy changes and what they mean for our agency, programs, partners, members, community members in general. And then we also have one that's dedicated specifically to changes upcoming in 2027. So depending on kind of what level of detail you're wanting to go into, we want to note those two resources for you. And we can go on to the next slide. Similarly, for our community partners and assisters, we want to note two ways you can submit questions. One of those is through the Office of Community Health and Engagement, or OCHE's ROCs, or Regional Outreach Coordinators, as well as our monthly Organ Health News webinar. We're kind of working on the email right now to get it updated so that we're making sure that folks are getting their questions to the right place. So we've removed that at the moment, but I'm hoping to have that back with an updated purpose here soon. You can go ahead to the next slide. And Nora, I think I'll just carry it on to the end if that works for time. Okay. So similarly, going to share some, we can go to the next slide and I'll share some additional links here. So if you heard today how wonderful newsletters and emails that come out from OHA can be, and making sure that you're up to date in the various programs. So if you're wanting to receive updates about OHP Bridge, you can sign up at the link on the screen, and I've dropped it in the chat. If you're wanting more information about OHP Bridge Advisory Committee, you can go to that website that's linked there. I also want to note, as we mentioned today, the slides, there were additional slides that didn't get presented at today's meeting. You can find them there. Currently, the ones that are posted are the draft ones. I'll be following up after this meeting with the final draft, so you'll have the most up-to-date slide deck. If you're wanting more information about OHP Bridge itself, you can find that at the link in the screen, which is just about the program and benefits and things like that. And it's got that FAQ that we mentioned and the flyers. So, and that'll be hopefully getting some updates over the next several months using the feedback that we received today. Really excited to come back at our next meeting and continue that conversation. And speaking of, we can go to the next slide. So just a quick reminder, our next meeting is April 16th from 1 to 3 p.m. And you, like I said, you can keep an eye out for those meeting details and whatnot at the OBAC webpage. Otherwise, thank you all for coming today. Thank you so much for a fantastic conversation and all of the feedback and thoughts and questions that you shared with us. We really appreciate it, and we're excited to see you in April. And I'll stay online for a minute or two so that folks can keep access to those links if they need them. Thank you all.
Bye. Thank you.